Good morning, everyone, and today we are going to talk about stroke rehabilitation. Remember, this is the continuation of the previous lecture. In the previous lecture, I talk about the introduction about rehabilitation medicine, and I talk about different kind of strokes. Also, I talk about the activities of daily life as well as um, the instrumental activities of daily life. Um, and then I briefly talk about the investigation in the start, how the important thing is to differentiate between hemorrhagic stroke and ischemic stroke, and because the management is different. So, of course, like in this lecture, we are going to talk about uh, stroke rehabilitation in specific. Now, of course, why it is important because stroke is very common, and of course, our aim is to bring back um, the person functionality to the previous level as much as we can. So as we know, that in stroke there is different type of impairments can occur depending on what is the size of the lesion, what is the site of the lesion, and what was the severity of the lesion. So you can say uh, every stroke patient is different, uh, but like someone have less disability, someone have more disability. What kind of disability is there? Of course, like there is motor dysfunction, like paralysis or paresis, which could be of the limbs, which could be of the oropharyngeal muscles, which could be on the face, which could be on the hands, or there could be paresis, which is like the weakness. There could be sensory dysfunction, which could be abnormal sensations or decreased sensations or no sensations at all. There could be sphincter dysfunctions like bladder. There could be cognitive dysfunction like anomia, aphasia. There could be emotional disturbance like depression, things like this. So of course, like motor weakness can be uh, like the general population. They think like whenever there is stroke, like the patients they present with hemiplegia. Hemiplegia, like their one side of their body is not working, or you can say paralysis of one side of the body. This is not the problem, but rather, you know, the face is also involved. There is later on they develop spasticity on the muscles. They may have dysphagia. Now, whenever there is muscle weakness, of course, due to that muscle weakness, there are many things which, um, what you can say, which can arise due to that. So, and same like with sensory impairment, they may have hyperesthesia or paresthesia or aesthesia, like there is absence of sensations. And so, like every person have different presentation. Again, different depend on what area of the brain is involved and how big is the stroke. And in perception disorder, there could be agnosia or alexia or hemi-neglect syndrome or disorientation, things like this. There could be even visual problems. So apraxia is basically when someone is unable to carry out the familiar task like which they used to do before. So there could be apraxia, there could be speech apraxia. So what it means, like due to stroke, their speech become incomplete. Maybe there is some distorted words, and depending on what is the type of aphasia they have. So um, now all the things, of course, like there is a lot of details about that. Uh, so now the important thing to talk about here is you can see over here, mm, neurological recovery from early spontaneous recovery, usually within the initial few weeks when numeral area recovers their function. And functional recovery is recovery in everyday function with adaptation and training in presence or absence of natural neurologic recovery. So, functional recovery basically lags this neurological recovery by 2 weeks. And this is the part which we help the most by rehabilitation. So, nowadays, there is a lot of research they have done, by the way, on the stroke, and there are a lot of predictors uh, which we can see. Uh, like which will guide us, like how the patient will respond, or how much is the recovery chances. Okay, so for example, like one of the predictor is uh, like what is the severity of the upper arm weakness. For example, someone who have complete paralysis of the arm, there is poor prognosis. Okay, but someone who have like just a little weakness of the arm, of course their prognosis is good. One of the predictor is that how soon the patient show some motor recovery. For example, when the hand is showing motor recovery by 4 weeks, so there are more chances that there will be normal or full or near full recovery will be there. So some of the poor prognosis of neurological recovery or motor recovery, functional recovery, that at 4th week, when 4 weeks are gone after stroke, if they don't show any grasp strength, if they have too much spasticity in proximal muscles, or they have a prolonged flaccid period, like whenever there is stroke, the muscles go flaccid, and later on they become spastic, or late return of uh, proprioception or proprioception for more than 9 days. So all these things, uh, uh, they predict what they tell us, like how the patient is going to respond. So of course, like how the recovery occurs, early recovery, there are some local processes, of course. When after stroke the edema is resolved, or the numera region started receiving the blood supply again, the toxins which are produced due to strokes, they are reabsorbed. Okay, and recovery of partially damaged neurons is there. So these are some local changes at that area which occur, which basically uh, bring back or direct the patient towards the normal functionality. And all the late recovery which is done, that is done by neuroplasticity. Now, if any one of you who is listening this is the like who are listening this lecture, firstly, I explain what is neuroplasticity in the previous lecture, and that's why I explain you this thing, just to tell you how we can train the neurons, how the brain can, or the neurons can make new neuronal connections, or how the brain area can be increased depending on how much you are using that muscle. So I have explained this thing in the previous lecture. So see, collateral sprouting of new synaptic connections, unmasking of previously latent functional pathways, and reversibility from diakinesis and denervation supersensitivity. So the things are same, written in a different way. So you can see, like, majority of neurological recovery in first 3 months, and 5% of patients continuing to show recovery for up to 1 year. Okay. So whenever anyone have stroke, first of all, they become like their muscles or their whatever like you're examining, they become like the area become flaccid, and later on it become spastic. Okay, and after that, um, like there is, you can say, um, uh, there is what you can say some um, regain of the functionality, and the patient basically overcome of all the synergies, and what happens like later on, the spasticity get decreased, and then there is a time that when all the spasticity is gone, and the muscles or the body, it come back to normal. So you can see over here, and this one is about functional recovery, improvement in independence in areas of self-care and mobility. Again, see, ideals and ideals are here. Dependent on quality and intensity of therapy, which is provided by the rehabilitation, dependent on patient's motivation, and it is functional recovery is modifiable by intervention. Now this one is, you can see like Copenhagen's stroke study, which shows that weeks from stroke onset and time course of recovery in stroke. So you can see like how many weeks are written over here, and these are the percentage of the people who get like recovered. So see, uh, this one, like all this legends are explained over here. You can see over here, all these signs are explained. See, the course of recovery is given for patient whose initial stroke severity was mild, this one, then moderate, this one, then severe, and then very severe. Okay, like this. So now, um, like what are the things, or what are the managements we can do in any patient, so that it's like it can bring back the function. You can see over 10% of the patients have complete spontaneous recovery. 10% do not benefit from rehab due to severity, and remaining 80% will benefit from rehabilitation. What it means, uh, that all the patients who need rehabilitation, you can say up to 90% of the patients, uh, they get benefit. Okay, so of course, like there are different factors behind that, but our aim is to bring back as much functions as we can. This is the primary goal of rehabilitation. Okay, and as I told you, that stroke rehabilitation is tailored for individual stroke patients. Okay, there are few things which are general measures which are done in any stroke patient, but then there are few therapies which are you can say, um, changed according to the patient needs. Okay, so in simple words, our main aim is to maximize function, maximize independence, and maximize or improve the quality of life. This is the goal of rehabilitation. So now, um, what are the principles? Identify impairments, of course, careful attention to comorbidities and complications. Early goal directed treatment, systemic assessment of progress and experience, interdisciplinary team, education, and comprehensive discharge planning. Okay, guys, remember this thing that before this, we take care in acute settings a lot of things about stroke. Because, for example, the patient who cannot close eyes, you can tape his eyes. If they have dysphagia, you have to pass an NG tube. So a lot of things are done before that. So rehabilitation is done once the patient is out of the initial attack. Person have gone through all those stages. So of course, like whatever rehabilitation you will do, early mobilization is very important. As you can see over here, if condition is stable, try to mobilize within 24 to 48 hours. Why? Because mobilization reduces complications. For example, DVT, deep vein thrombosis is a complication. So early mobilization can decrease that. It have strong positive psychological benefit, and tolerance for therapy affected by stroke severity, medical stability, mental status and level of function. So you can see early mobilization, physiologically sound changes in bed position, range of motion exercises, specific tasks like sitting up, turning from side to side, and self-care activities like feeding, grooming, and dressing. So basically, you can say that like there are some traditional exercises like full range of motion exercises, strengthening exercises, mobilization things, and some compensatory techniques. So all these things, of course, what they why they are doing this thing? Just to improve their motor control and also um, you can say to increase their coordination or bring back their coordination. Okay, so secondary complication of the stroke, you can see over here that there are many like recurrent stroke, uh, deep vein thrombosis, pressure sores, bowel bladder dysfunction, and dysphagia. So for that thing, by the way, uh, like just to explain you these things quickly, because I think like if you are doing plastic surgery now, which is done in the last semester, you know what is pressure sores, right? How it is treated. So of course, like that thing we all know. So the thing here is that pressure sores, as we know, that it develop um, on the areas which are under pressure in a patient who is bedridden, like on ischial tuberosities, on the occiput, behind that, like on the elbows. So of course, like high risk patients are those who are immobile completely, who have diabetes mellitus, who have peripheral vascular disease, who have low BMI. So in the stroke patients, not just the stroke patients, any patient who is bedridden, they keep on examining their skin time by time so that any skin changes can be recognized and can be managed early. Because once the pressure sores are developed, of course, they are hard to manage. That's one of the reasons why they put the patients on air beds or air mattresses, uh, like which keep on changing the pressure points, or why they put some special type of, you can say, supports or pillows under the patient who are bedridden for so long, so that they should not develop pressure sores. So proper positioning, turning, and during transferring, avoid skin injury from friction or excessive pressure. So whenever like even they have to transfer patient from one bed to another bed, they really take a lot of care. Like instead, like they put something sheet under the patient and then they move it instead of like dragging the patient on the sheet, because that also produces friction. Bladder and bowels, see, there could be urine incontinence, there could be constipation, um, and things like this. So of course, like these things should be managed. Then there is dysphagia. Of course, like due to bulbar muscles weakness, they cannot swallow like normal persons, which can lead to choking, or which can lead to like the food material or the food particles can go into the esophagus, trachea, can go into the lungs, can lead it to aspiration pneumonia. So that's why after stroke, one of the thing they do their assessment, okay, swallowing assessment, like either the patient can swallow or not. Because if the patient cannot swallow, um, in the initial period we can give them feed by NG tube, but later on there are some techniques which can be used to improve dysphagia. So video fluoroscopy swallowing studies can be done. So in this one, what they do, like they give a contrast to the patient and they ask them to swallow, and they take the picture. uh, it's not a photographs, like it could be multiple photographs, or basically it's a small video these days which show how the dye or that contrast is going from the mouth into the esophagus. Or we can do functional endoscopic examination of swallowing. So these things are used. Okay. So now here comes the criteria of um, stroke or sorry, rehab program. For admission into the rehab program, you can see like stable, like when someone have stable neurological status, have significant persistent neurological deficit, we must identify the disability affecting at least two of the following, like mobility, self-care, communication, bowel, bladder, or swallowing, or simply any two ADLs are disturbed, right? And they must have sufficient cognition to learn, of course. If they don't have sufficient cognition, so whatever you will do, of course, it will go useless because the patient cannot learn that things. And sufficient communicative ability to engage with therapist, and physically ability to tolerate active program. And there should be achievable therapeutic goals. Of course, like if the goals are not achievable, so it will be just waste of a time, because whatever you will do, whatever the therapy or whatever the treatment strategies you are applying, of course, if the patient don't have the ability uh, to tolerate that, or if you don't have any therapeutic goals, or for example, if the patient don't have a sufficient cognition, of course, like all these things will be useless. Whatever you will do will not benefit the patient. So one of the thing, by the way, um, if you will see, like there is international classification of functioning. Okay, so what is international classification of functioning? It is also called as FIM score. Okay, FIM, FIM. That is called as functional independence measurement. Functional independence measurement. Okay, and of course, like there are a lot of other things as well which are there, but I'm talking about the general things. As I start my lecture, I told you there could be motor, there could be perception, there could be visual, there could be cognitive, there could be communication problems, right? So there could be any impairment like this, which you can or you have to improve by the help of rehabilitation. Um, so what are the outcome measures? Stroke severity, again, NIHS is like a system by which we can check upper and lower extremity function. So like these are all the, you can say, um, um, you can say like these are all the way of analysis, or like um, ways how you can analyze or evaluate any patient, like what will be the effect of this therapy on this one. So same like, okay, I will show you one like FIM score, functional independence measure. There are 18 items. You can see like a lot of items are written over here. So scored into one of 7 levels of function, ranging from complete dependence level 1 to complete independence. So of course, like if someone is getting 7 score, like it means they can survive without any caregiver help. But of course, like patient is getting level 1 score, so which means like the patient is dependent on others for everything, right? So same like there are other scores which I show you, and each score is there to check different type of disabilities, a different type of um, clinical picture, you can say. It can give you a good insight about where the patient stands. Okay, so uh, these things. Now, of course, like many things can be done. You can ask the patient to walk. You can ask the patient like how much ADLs they can perform. You can check their sitting balance, either they can sit balancedly or not. You have to check their cognitive level. Okay, how much learning and memory impairments they have. These are the most common one, by the way. You have to check their comprehension. You have to check their expression level. All these things are there. Okay, and same thing with cognition. You are going to check the cognition as well. So now See, what are the rehabilitation goals? They should be specific, they should be measurable, they should be achievable, they should be realistic goals. They should be like all these goals or all this therapy should be done timely to get the best results. Now, as I told you yesterday, like there is number of doctors. So even in rehabilitation, there is a number of doctors. You can see, uh, you cannot say doctors, like you can say healthcare workers. Okay, like rehabilitation physician, nurse, physiotherapist, occupational therapist, speech therapist, psychologist, social worker, prosthetist and orthotist, like which make prosthesis for the patient, and dietitian. So of course, like all this team, they work together for the patient, um, to improve their quality of life, to bring back their functionality, or to improve their functionality, to improve their um, weakness, or at least like overcome all the disabilities or impairments they have by other means. Okay, what are the means? Of course, we will discuss them in detail. Stroke rehabilitation can be done in inpatient, as an inpatient, as in community hospital, in a nursing home, in daycare rehabilitation centers, sometime home-based therapy. For example, community rehab programs are also there. So see, for example, this one, if you will see, someone due to stroke who cannot even recognize himself, so what they are doing, they put the patient in front of the mirror, so the patient keep on looking themselves, and by this way, um, like this is just to make them aware, self-aware, okay, that they're there. So this thing. Okay, so for example, this one, if you will see, like they are improving the mobility and balance, but here see they are using the crutches or different walking aids. Okay, here, like each one of photograph, of course, shows how the doctors are or the rehabilitation experts are helping the patient to let them walk, or let them walk independently. So one of the things is like in stroke, which in which like by which we can improve the upper limb function. You can see over here functional electrical stimulation. So now, what is functional electrical um, stimulation? It's basically, as the name shows, that it is like stimulating uh, the muscles by the help of, you can see like they put the two electrodes, right? So actually, this is proven, that when they use this kind of therapy, it do have a um, good effect on the patient, right? So functional um, electrical stimulation can be done in these patients, okay, which improve the outcome. Muscle contraction is there, of course, like by this functional electrical stimulation. So this is one of the things, um, which can be done. Okay, then there is, you can see over here, they are doing rehabilitation by like let them then learn how to use the left hand. Okay, for example, um, someone who have the right hand, who are right-handed, you can say, as a result of stroke, when they cannot use anymore their right hand, so and there is no movement at all, or there will be no recovery at all, depending on the predictors, how the predictors are going. So of course, like there should be a realistic goal. If you know that, that even by giving rehabilitation to the right hand, there will be not much functional improvement, that the patient can use his right hand. So of course, like the best way, or you can say the realistic goal in this case would be what? To teach the patient how to use their left hand to write or do the work. This is like again a stroke rehabilitation patient who is teaching how to self-care. Okay, see, like teaching how to dress up, see how he support his left right hand with the left hand, put the shirt, and uh, like how to button them, things like this. So now there are theories behind this thing, okay, like how this thing happen, or things like this. So actually, if you are interested, you can go and read some theories, but uh, basically, um, this type of things, if you are not uh, a rehabilitation specialist or working over there, of course I don't think so like they are going to help you much. So for example, one of the thing, which is used in stroke rehabilitation a lot is repetitive task training. Like they ask the patient to do some movement repetitively, okay, repetitively, repeat it again and again, right? That's it. So this is again photographs, you can say, in which like they are uh, rehabilitating, or you can say making the patient to recover, or to train them in ADLs or IADLs instrument. Look, you see, he's putting water by the jug, or shopping, or anything like this. Okay, dysphagia is very important, right? And as we know that, as I told you, like dysphagia can occur, right? Not just dysphagia, but speak like aphasia as well. So basically, these speaking and swallowing difficulties are common after stroke, and more common when the stroke is in posterior circulation, which basically um, damage the brainstem, you can say, or subcortical structures. So remember, like, what is dysphagia or dysarthria? Dysarthria when we cannot articulate due to muscle weakness, and of course, like all the facial muscles, they are supplied by the cranial nerves. Or for example, there could be incoordination of the muscles, right? And whenever, like, due to bulbar muscle paralysis, like again, which is like supplied by cranial nerves, it can lead to dysphagia. Okay, but when the brain or the higher cortical um, areas can be can be damaged, it can result into dysphagia. So facial muscles dysarthria, then dysphagia, and then dysphasia. So of course, like uh, they evaluate dysphagia, and the speech therapist is there who basically help them, or who try to bring back uh, as much functionality as they can in the patient, right? And of course, like there are many ways to do that, but of course, like the speech therapists are those uh, who know better, like how to do that. Okay, so things like this, of course, like they know better. Okay, um, how to teach them how to eat. Okay, but like there is a way called as chin tuck. What is chin tuck? Like uh, uh, like they can bring the chin towards their uh, chest, you can say. Basically, that protect the airways, and the liquids or things, they cannot go into larynx. Okay, for example, while eating, they can do head rotation. Okay, head rotation closes ipsilateral pharynx. So of course, like the food goes into the contralateral pharynx, or head tilt can be done, or supraglottic swallow is there. So there are many maneuvers, right, which can be done. Okay, because if you are not going to treat dysphagia, it can lead to pneumonia, it can lead to malnutrition, dehydration, things like this. Okay, so uh, same with aphasia. You can see improving communication. So if you will see over here, like they are using special uh, newer techniques like the tabs, or before, of course, there were charts in which, for example, 1 to 10 is written, or smiley faces there, sad faces there, angry faces there. So like they used to communicate the patient like this. When they have to say yes, they can point yes. Whenever they have to say no, they can point no. Okay. So of course, like anyone who have aphasia, depending on like either it's receptive or expressive, uh, or you can say like fluent or non-fluent. Then many things we check, like either repetition is intact or comprehension is intact, because depending on like either Wernicke's is gone, or Broca's is gone, or arcuate fasciculus are gone. So that is decided on that. For example, whenever the Broca's area is gone, um, there is non-fluent aphasia. But whenever there is Wernicke's is gone, there is fluent aphasia. Okay, so things like this. So of course, like aphasia, speech therapists are those uh, who basically treat that thing. Okay, there are many different terms which you will found in rehabilitation books, like paraphasia. Like paraphasia is when they want to say some word, they basically substitute the word from for with some other word which is basically incorrect. Okay, like uh, they can use the word, if they have to, okay, they substitute with the word which have the similar sound, you can say. We call it as paraphasia. For example, if they want to say you that um, uh, can you hear that sound, so they will say can you hear that found. Okay, so found is to find something, and sound is of course voice or something which you can hear. So they they can substitute found with sound or sound with found, and all the similar words which sound similar. Okay, things like this. So they can substitute chair with fair, things like this. Then there's something called as agrammatism, in which like they forget the grammar. The like grammar, their sentence structure is wrong. Grammar, like if you see from grammar's point of view. Then there is anomia. For example, they cannot recall the words. Sometimes there is echocolia, echo, echolalia, like repetition, echoing of the words. Okay. Sometimes there is circumlocation, like uh, whenever they are trying to recall something, they will be talking the things which are related to that, but they will not talk about that thing. Sometimes there is a neologism. So what is neologism? Like when there is a new word. So of course, when they use a new word, like which you never heard, basically, that is like you will not understand that thing. So of course, like uh, there are many techniques by which they uh, try to manage this thing. This is the job of a speech therapist. Okay, they have special techniques. Okay, uh, which by which like they can modify uh, their condition. So these are late rehabilitation issue, like psychological maladjustment, depression, sexuality, vocational driving, equipment needs, spasticity. Then okay, many people they have like most of stroke patients they have hemiplegic shoulder pain, which can be due to rotator cuff injury, spasticity, subluxation, complex regional pain syndrome, or contractures. Sometimes they have central stroke, like post-stroke pain. So like of course they then we have to of course deal with the pain. Okay. So of course like everything is understandable. Depression is understandable. Sexuality is understandable. Okay, because of course, like after stroke, their uh, sexuality get decreased a lot. Okay, they have fear, they have anxiety, they have guilt. Some of the patients have low self-esteem. Some of the patients, they have fear like the partner will reject it, things like this. So all these things are understandable, right? So you can see spasticity now. Spasticity, as we know, why there is spasticity. In the initial period, there will be flaccidity, and later on, there will be spasticity. So, spasticity, as we know that, uh, okay, one thing by the way, guys, maybe you are thinking like I'm taking too much time on stroke, but it's not about taking too much time, it's about rehabilitation techniques are same. If right now I'm talking about stroke and I'm talking about how they let them speak or how they let them walk or how they let them transfer, whatever is the impairment, either it is due to stroke or spinal cord injury or amputation or rheumatoid arthritis or any muscular disease, of course the techniques will be same. Okay, so when we will do one thing in detail, rest of the things will become easy. So talking about spasticity, if you'll see over here, the limbs should be properly positioned and passive ranging and stretching should be done. FES can be used, which is functional electrical stimulation, and they can use some pharmacological drugs. I think you are well familiar with these drugs: baclofen, clonazepam, and dantrolene, which are basically muscle relaxants. Okay, which are given to the patients with spasticity, given to the patients who have muscle cramps. Okay, things like this. So of course, like the same drugs can be given to the stroke patients because spasticity is very common. Okay, so spasticity uh, develop and the patient they feel pain as well. So stretching, they can use some casts, they can use some splints, they can use electrical stimulation. Okay, um, drugs, all the drugs are written over here. One of the drug is tizanidine, by the way. So uh, they can be given. Sometimes they use neurolysis, right? Alcohol or phenol, or if you know, nowadays very famous when they use botulinum toxin. Okay. Sometimes they give intrathecal baclofen by the use of pump. Uh, so all these things are surgical options: intrathecal baclofen pumps and tendon release. Okay, these are you can say not so much used nowadays because like that their need is not so much nowadays. Okay, so most of the cases, of course, they become better like without surgical options. So surgery is rarely needed. This is the thing which I was talking before, the stage of motor recovery. I told you um, whenever the patient have had stroke, they go into flaccid paralysis. There is flaccidity. Later on, some spasticity with weak flexor and extensor synergies are there. And then this spasticity become very prominent and there is voluntary motion occurs within synergy patterns. Okay. Then of course the patient overcome these synergies and what happened, like the patient come back to normal with some isolated movements and later on like restoration to normal, or you can say near normal, not completely normal. Okay, shoulder pain is very important topic. Wait, and that's why yes, I will show you because see, a lot of things are shoulder things are there. So guys, shoulder pain is very important. Okay, and there are multiple reasons behind that because the patients who have stroke, they have, you can say, some complex regional pain syndrome as well, right? So now 70 to 80% of patients with hemiplegia, they basically present with shoulder pain. Okay, and most of the shoulder pains basically develop during the spastic phase of recovery. Okay, so now uh, basically the most common cause of shoulder pain is called as complex regional pain syndrome 1, or CRPS1, complex regional pain syndrome 1, which is also called as, I don't know if you have heard about that is called as Sudeck atrophy. So basically what happened is there is sympathetic related pain. Okay, there are some sensory abnormalities, there is abnormal blood flow, there is abnormalities in the motor function, and all these things, all these things basically they cause burning type of pain with swelling and edema. Okay, um, in patient. So anyhow, that is not the only reason, right? There are many other reasons as well. For example, many of the patients, they have shoulder subluxation. Okay, shoulder subluxation, like the shoulder joint is not dislocated, but it is not at its normal place. And how we can feel it? Basically, we compare both shoulders and we see what is the gap between the acromion and the humeral head. So basically, the shoulder which have pain, they have increased gap, which means like the shoulder is subluxated. Okay, the shoulder is subluxated, it's not at its original position. So I will not go into the details of that. Of course, like there are causes behind that or the factors which lead to this thing. Okay, so for that case, what they do is like basically they put the patient in shoulder sling. Um, Sling. Okay, like they put the hand in the shoulder sling. I think like anyone who have a broken hand, you have seen like how slings look like. Okay, and um, shoulder sling can be used, and again functional electrical stimulation can be used. Um, okay, many of the patients, they have shoulder pain because of bicep tendinitis. Okay, and many of the patients, they have, as you have seen over here, shoulder pain. It can be due to rotator cuff tear. I think like before there was a slide in which all the things are written. This one, rotator cuff injury. Okay, spasticity, subluxation, complex regional pain syndrome, or contractures, right? So of course, like all these things you have gone through before. So in short, like many patients, they do have this shoulder pain, and due to this shoulder pain, they may have pain. You can see the photograph of subluxation, and you can see over here, this one is a sling. Okay, this is a shoulder sling, which is basically supporting the whole arm, and this is the positioning of the hand which can be used. Okay, reduction of subluxation in sitting and standing, dynamic joint compression of shoulder, elbow, and wrist can be done during standing, and avoid pulling on affected arm during transfers. These things, all things can be done. And functional stimulation, functional electrical stimulation can be done of these patients. And also, okay, one of the causes of the shoulder pain is subacromial impingement. Of course, like then we will treat it as impingement. Okay, guys, I think like the lecture is quite long, and actually, it takes a lot of time to upload when the lecture timing becomes so long. So I'm going to finish it over here, and in the next lecture we will continue right from here, um, from the next topic which is coming out of here, and I hope so. The next lecture will be last about the stroke, and then we will move on to the rest of the topics. Okay, so I hope you understand and enjoy this lecture. I will see you in the next lecture. Thank you.